Good morning. I am Mikael Mazighi, working at Lariboisière Hospital in Paris, France. And I am glad to present you the results of the ACTIMIS study. And I will introduce the topic with a small word regarding the drug which is currently evaluated in this study. The drug's name is glenzosimab. And this is an antibody fragment targeting specific glycoprotein of platelets, the GP6, that you can see on the top right side of the slide. This glenzosimab drug has specific antithrombotic activity and has no effect on hemostasis. So this is supposed to be a no bleeding medication, and that's a need to be proven, and that was the reason of the study that we're going to see in a minute. So there are two aspects with this drug. There is an add-on effect on the platelet thrombi formation at the site of fibrinolysis, which enhances the reperfusion. And there is a standalone effect on microcirculation targeting a thromboinflammatory process going on in the downstream microcirculation that are involved in the hemorrhagic transformation. So the ACTIMIS trial was a safety evaluation of this glenzosimab within 4.5 hours in the setting of acute ischemic stroke patients receiving either IV thrombolysis or IV thrombolysis and mechanical thrombectomy. And you can see here that there were two phases. Phase 1B with an escalating dose from 125 milligrams to 1000 milligram of glenzosimab. And you can see that 48 patients received glenzosimab and 12 patients had the placebo. And then there was a phase 2A with the recruitment of 100 patients who were randomized to receive either placebo or 1000 milligrams. This was the chosen dose because there was no increase in bleeding rate observed in the phase 1 study. You can see that 6 European countries were involved in this study, and the primary endpoint was safety with serious adverse events, including death and ICH, and there were secondary endpoints with NIH at 24 hours and the ranking scale at 3 months. So the main results you can see here, there was a significant reduction in intracranial hemorrhage with 1% of symptomatic ICH in the glenzosimab group versus 7.8. And there was also a reduction of all-cause deaths from 19% in the placebo group versus 8% in the glenzosimab group. If you make a focus on the patients, the most severe patients who were eligible for mechanical thrombectomy, you can see that on the right side of the panel, that the reperfusion scores with the MTK were higher in the glenzosimab group, 96% versus 85% in the placebo group. It was also interesting to see that again, in this subgroup of patients who were eligible for mechanical thrombectomy, there was a reduced mortality, but also a shift with a reduced MRS-3 in this specific subgroup of patients. So in conclusion, we can say that glenzosimab administration in the setting of acute ischemic stroke within 4 hours and 30 minutes was associated with a reduction of intracranial hemorrhage, both symptomatic and asymptomatic, a reduction in mortality, and some post-hoc analysis suggests that there may be an efficacy trend in patients were eligible for mechanical thrombectomy. Thank you, and I'm happy to discuss with you these results.